Welcome to the Practice of Medicine podcast from the Southern Medical Association. Since 1906, SMA has had a singular mission to provide medical professionals with the resources they need to learn from each other and in doing so, improve the overall quality of patient care. The Practice of Medicine podcast is just one of the ways we do that, as we discuss a wide range of topics including multidisciplinary approaches to patient care and new innovations in medical technology. To learn more about SMA's many other services and educational initiatives, please visit us at sma.org.
Transitions of care is one of the most complex and often one of the most problematic aspects of healthcare systems, leading to errors and negative outcomes when not done effectively. However, it is rarely taught in undergraduate medical education, and when it is typically in the classroom setting. Today, we are joined by Drs. Shireen Salib, Clarissa Johnston, Michael Brode, and Ms. Abby Amidon to discuss a novel transitions of care elective they developed and implemented during the COVID-19 pandemic, a topic addressed in their upcoming Southern Medical Journal article. Well, thank you again for being here today. We really appreciate your spending some time with us. And to get the conversation started, I will hand it over to Dr. Holt.
Well, I echo what Mrs. Price said. Thank you all for taking time out of your busy clinical and educational days to spend some time with us. Your forthcoming article is really stimulating, and I think you have a very wide interest among the readership and the listeners. So it's very important that we get your thoughts and you can convey them on to those who may benefit in their own institutions and programs. So if I may start with Dr. Salim, it's certainly nice to have now faces with each of your names and to know we're only 60 miles apart between Austin and San Antonio. In this article, Dr. Sleep, a novel Transitions of Care Elective Value-Added Medical Education Innovations During the COVID-19 Pandemic and Beyond. We noted an emphasis on the intrinsic risks to patient care during the transition of care phases, typically from outpatient to from inpatient to outpatient, but not limited to that setting. Can you please explain to the listeners the background of this issue of transitions of care, the challenges in improving undergraduate medical education on how these transitions are taught, and how the pandemic challenges led you to focus on the issue of patient care and medical education?
Certainly. Thank you so much, Dr. Holt and Mrs. Price, for the invitation to join you for the podcast. And thank you for this important question, Dr. Holt. I do think that it is easy to underestimate the importance of transitions of care. So I wanted to take a moment to describe the intrinsic importance of transitions of care and the potential hazards that can be associated with transitions of care. So the Joint Commission defines transitions of care as movement of patients between healthcare practitioners, different settings, and home as their condition and their care needs change. And importantly, as you pointed out, the transition between the inpatient and the outpatient setting is one that is particularly fraught with potential missteps. The transitions of care is particularly complicated time for patients, and the errors that can occur during that time can contribute to negative outcomes, including hospital readmissions, medication errors, and lack of follow-up. It's important to really emphasize here that vulnerable populations often experience more barriers to successful transitions. And I want to take a moment to highlight that when the COVID-19 pandemic struck in our midst in Austin in the spring of 2020, it really presented a unique challenge as well as important opportunities. The pandemic exacerbated many of the transitions of care challenges especially for the vulnerable populations that we serve. Those include our uninsured and underinsured patient populations, as well as those with a language discordance, many of whom did not have a medical home prior to the COVID pandemic. That patient population we found typically experience a lot of barriers to effective care transitions, and we saw that the pandemic really highlighted those barriers.
How did you and your team construct the transition of care teaching elective for medical students, and what are its important educational elements?
That's a great question, Mrs. Price. Thank you so much for that. So when we first experienced the complications of the COVID-19 pandemic in the spring of 2020, our students were temporarily removed from the clinical setting. And they were out of the clinical setting for a few months, as was the case around the country. And we used the disruption of the COVID-19 pandemic to implement some new curricula, some innovative curricula. One of those was the new transitions of care elective. And as far as I know, I don't think there is any similar elective nationwide, even based on our literature review. So the elective for medical students, this transitions of care elective, use the approach of what's called value-added medical education, and we can come back to that in a little bit. And it was a true collaboration between many. It was led by some of the folks on this call and many others. So Dr. Clarissa Johnston from palliative care, Dr. Snehal Patel, Dr. Mike Broad, as well as myself, as well as many others. And what we did is we started with a one-week pilot where 2 volunteer students performed the duties that helped us outline the workflow of the elective. It was an opportunity, the pilot was an opportunity to ensure that the logistical aspects were worked out, such as the ability to have seamless virtual communication. So the elective for the students was all conducted remotely. And so during the pilot, we worked on ensuring that there was clear communication between the students who were working remotely and the teams who were in the hospital. And we wanted to ensure that the students were also able to communicate with the patients and the families remotely and virtually. The pilot went very well, and we rapidly finalized the details of the course. And we offered the elective to students in their 2nd, 3rd, or 4th year of medical school. Essentially, the students received a virtually conducted orientation on the first day of the elective. And subsequently, we embedded the students into the hospital-based academic team model. As they worked remotely, they participated in calls with the team. They participated in multidisciplinary rounds, as well as calling into patients' rooms, calling into the various other interprofessional care providers. On average, each student participated in the care of about 5 to 6 patients at any one time. There were really 3 main components to the elective. One of them was participation in team activities that I already alluded to. The other was communication, really teaching the students how to be part of critical and difficult communications, because many of our patients at that time were going through difficult end-of-life decisions, and the students were part of that, and they contributed to those conversations remotely and were part of the team. And thirdly, they contributed to discharge planning. So it was a challenge, it was a logistical challenge, but it was one that ended up working very well.
Thank you. This is a very interesting program, so thank you for sharing a bit more about that.
Minutes ago, Dr. Salib, you mentioned value-added medical education. I think all of us in healthcare understand the concept of value-added medicine. But this idea of value-added medical education is quite intriguing. How do you define it, and how did you work that into your elective?
Thank you, Dr. Holt. It is value-added medical education is an emerging term that we're hearing more and more of in medical education, but you're absolutely right, not necessarily familiar to everybody. So the definition of value-added medical education is it's experiential learning where the students not only have a robust educational experience, but where their work also adds value to patient care and teamwork. So the transitions of care elective was an ideal setting for highlighting the importance of value-added medical education. Not only did students learn about transitions of care, which is often undertaught in the undergraduate medical education setting. So they learned about this and they were fully immersed in this experience. But concurrently, they were able to actively participate in patient care and add value. Their work actually made the patient's experience better. They helped the teams. We actually had several teams come back to us and ask, are we going to continue this? The students were so valuable. Let's please make sure that students are always involved in transitions of care. So in a nutshell, value-added medical education helps everybody, helps the students from an educational perspective, but also importantly adds value to the patient's care as well as the teamwork.
I hope your explanation on this podcast and the article will help spread that concept farther across the country.
I hope so too. Thank you.
We would now like to talk to Dr. Clarissa Johnston. And Dr. Holt, if it's all right, I will let you begin that portion of the discussion with our first question for her.
Johnson, welcome. You're a clinician, and so you were part of the struggle during the pandemic that all physicians had to define their interactions with patients using remote visits and other challenging contact elements. Communication skills have always been important in the patient-physician relationship and very fundamental to caring for patients. But this past year, communications have been quite challenging. Not only outside of the examination room, but even within the examination room. And the hospital, certainly. How have you been able to use the pandemic situation in this area of communication as a teaching and learning experience for your students?
So happy to address that. Thank you for that question. So I do about half my clinical time is hospital medicine. So I was taking care of a lot of COVID patients. And then the other half of my time is as a palliative care physician. So doing a lot of the communication specific work. And as everybody else experienced, we had so many issues trying to communicate with all the barriers that were placed by COVID. So I think one thing that was important was for all of us to take a step back, particularly with our students, and just be intentional. So much of the communication we do on a daily basis with patients and families is we just go in the room and we see them and we're with the team and we communicate. And so it's easy. We don't have to think about it. We need to think about, are we doing a good job with the communication? But the communication part comes naturally because we're together. And so, of course, with COVID, we were not together. So it really was a time to take a step back and say, I need to communicate with the family in particular every day. And I'm thinking mostly of our intubated patients in the ICU because we really could not communicate with the patients themselves. And that was such a huge challenge for all of us. So we did a number of things to try and improve our communications, and working with the transitions of care students was really helpful with that. Again, as Shireen mentioned, Dr. Salib mentioned, with ValueAdded, the teams were overwhelmed with the work they had to do. And then having to reach out and call families every day is a lot of extra work. And these often were long conversations. They were often having to use an interpreter because they were in a translator, they were in different languages. So that was one place where Transitions of Care was able to step in and help. We would do the communications. And since we were doing the communications, this was a great opportunity to say, hey, let's talk about how we're communicating. and using some basic principles of communication, especially serious illness conversation. I think most of our students and our faculty and residents are great. We look people in the eye and introduce ourselves. I think communications 101 we have down, but this was an opportunity to work on serious illness conversation to move things up. So we used the Vital Talk method and did some real basic skills. Like one is what we call a headline. So giving a 1 or 2 headliner to the family. So kind of what we would do on rounds, 29-year-old man, blah, 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 blah. But doing a similar thing for family in patient-friendly, family-friendly language that also delivers a concise message. So, your loved one is on the ventilator, we have had to paralyze them, and they are on the maximum amount of oxygen, and we're having a really hard time keeping them going. And I'm really worried that your dad is not going to survive this hospitalization. So those are really hard things to say. And you obviously don't just open up the phone call with that. But we found that the teams, we would call and do that, and the family would be like, no, the ICU just told me they're doing better. They're on 90%, not 100%, FiO2. And you'd be like, no, they're not done. That's really not what's going on. So it was a good opportunity for us to work on some very specific skills. We used headline skills and also, introducing ourselves, even doing an intentional introduction and doing what I sometimes like to call asking the big question, not the little question. The little question is, hi, it's Dr. Johnston. How you doing today? Right? Oh, great. How are you? My life's falling apart. We all have COVID at home. We have no source of income, and my husband is in the ICU about to die, but I'm doing fine. That's not really an introduction to hear what's going on. So asking the big question, which is like, you have a lot going on. How are things going at home? This is how your husband's doing. How are you doing? How are you doing? So really doing an introduction and being open to asking some of the bigger questions were other skills that we worked on. So I think it was a great time because we spent so much time on the phone. It was perfect. I could have the students start the conversation and then I could jump in, if and these are hard conversations for faculty to have. So it was really, I thought, exciting that we were letting students really jump in and do this in a protected environment and then getting direct feedback immediately after the phone call.
Excellent perspectives. Thank you very much for sharing that with us.
The physical isolation from patients during the pandemic has been a daunting challenge for both patients and physicians. The philosophical expression of our profession has been the laying on of hands. Have we lost some of the humanistic approach to caring for patients when isolated from them? And how should we maintain humanism with patients under such constraints now and in the future?
Yeah, so I think this issue brought up a huge amount of moral distress, I think, for nurses, for physicians, for respiratory therapists, really for everyone in the hospital. And I think that we still need time to process that experience. We do Schwartz rounds at our hospital, and we've had 2 Schwartz rounds. I don't know if people know what Schwartz rounds are. They're a setting where we talk about challenging, difficult cases or difficult issues. It's for everybody in the hospital, not just the care providers. And it's a place to sort of process what we've gone through. And it's generally to help promote compassion in caregivers. So anyway, that's one setting where we've been able to talk about that. But I think in terms of direct things at the bedside, like what can you do when you are so isolated from patients and families? And there are a number of different ways that we addressed it. I know that other facilities did. We started a program called Meet My Loved One. And actually we generously was given the idea and the sort of framework from UAB, from University of Alabama, Birmingham. Their palliative and supportive care department helped us with that. And I think that was one of the, there was a lot of sharing going on during COVID. But what we would do is have one of the transitions of care students call the family and ask a series of questions of the family about their loved one. What name does he like to be called? What are his favorite things to do? What's his favorite food? What does he like to do when he's not working? And we would, with family permission, we would post the results of that on a sheet outside the room. And it was really a fantastic success. The nurses in particular loved it. It gave them something to talk to the patients about, And our ICU team, when they were rounding, a couple of the attendings would always start with the patient. Okay, we're here with Mr. A and 317. We have a new Meet My Loved One up there. Can somebody read that for us? So just a way to be like, okay, this is not just a physiology problem that we are dealing with, but let's remember there is actually a person behind, behind this. So that was really, I think, successful and helpful to get people to think about that. We had daily multidisciplinary rounds where we would, with the palliative care team and the ICU team, physical therapy, all the usual people. But it was a time to also talk about what was going on with the patient, what was going on with the family, what their personal struggles were, what was going on with their lives. So I think those were all sort of ways. It's still a challenge. It really, really is. And one of the things I noticed the most is how much one of the most important things as a physician is to establish trust with your patients. And we do that in so many innumerable ways that we don't realize we do. But when it's taken away from us, it's that much harder to establish trust. And video visits and phone calls, just don't have. So I know for us, we now have liberalized visitation policies in the hospital now that we have a better idea of how COVID is transmitted and, what's appropriate safety measures. And so that also has been helpful to be able to allow families to come in for many of our patients.
I might just add, I've heard of some ICUs here in San Antonio where the providers asked for photographs of the patients, maybe patients and their families, in a very pleasant setting, posting them inside the room so that the providers have a little sense of the other side of the patient, what their life might have been.
Yeah, that's another wonderful way. I think we did on some of our Meet My Loved Ones, we would post a picture as well. I think anything you can do, families would bring things in. We had a family who brought some things, for us to put in the room. We were limited in what we could do, but even just having something that was important. I think one patient was a fan, his favorite soccer football team in Mexico. So they brought in a little, doll of the mascot. And that was, just having that in a room, and you see that and you're like, oh, this is a person. This isn't just somebody who's on FiO2 and their PEEP. And so those things are all really important.
And things like that, because we had some family friends whose loved one, they were in the hospital. And even for the ones who weren't hospitalized, being able to have that connection helped them too, not so much for the patient, but everybody's mental health was kind of taking, taking a hit. It became aware. They said, well, this is something we can do. We can remind our loved one that you are not forgotten. We're doing everything we can. And we want your care team to realize your person. So it made them also feel like they were doing something while showing those in the hospital, this is my loved one. So I think what you're doing is wonderful. And I think it has a very positive impact. So thank you. All right, we have some questions for Dr. Broad, and much like we did with Dr. Johnston, Dr. Holt, if you would like to start the discussion with him, we are ready when you are.
So Dr. Broad, we understand you are considered a frontline provider, and you brought some unique perspectives to the transitions of care elective team in terms of practice operations, which is something that a lot of students don't get exposed to, I think, during their early education in medical school. Can you please describe your own thoughts and perspectives regarding the importance of teaching the transitions of care and how they might have impacted the creation of the elective?
Yeah, thank you so much for that question. I think it's really interesting in kind of our traditional both care model and both teaching model. We really think about our care delivery in really discrete silos. And so, of course, that I feel like a lot of transitions of care are in the hospital. We're waiting on that echocardiogram. It gets read at 2 p.m. And then we say, okay, patient's ready to go. And we just, have a process that just starts to get the patient out of the hospital as quickly as possible. And as intentional as we try to be about
education, making sure they have good follow-up. A lot of it really happens in the background. And once that discrete episode in the hospital is over, the patient is out of mind for the care team. And that's what a lot of our training is focused on. And so, we're at Dell Medical, we're really trying to do better than that and talk about the care continuum. But COVID-19 really gave us the opportunity to think really about the discrete parts of all that needs to happen and really forced us to. It's funny, a year later, this is almost routine, but a year ago, we had to think of every single piece. Are we assessing the patient's ability to self-isolate at home? Will they be able to get food at home? Will they have support, and who will they call if they're experiencing decompensation? And at the same time, not just thinking about this in terms of the patient right in front of us, but also COVID-19 forcing us to think of, we're not just caring for the patient in the hospital, but the family unit and the public health in general. And so really having to be intentional about each portion of that transition of care. And are we planning for it? And are we offering resources, interventions that are going to meet those needs for every single patient? And so I think it really forced us to think through each aspect and to really have to teach that to students of what makes a good transition. And I think we were pretty intentional, not just transitions out of the hospital and making sure patients really had follow-up, but also within the hospital, having the students start to have these tough discussions, as Dr. Johnston talked about, with the patient in the ICU. But as many of these patients did better and went to the floors, that the students could transition them with them and really be responsible for that warm handoff to the new care team, not just in the physiology and their oxygen requirements, but what are the social needs? What are some of the communication needs, and who's been the point person for the family? And to really be able to bring that warm handoff and be that continuity between the teams really was an extra value, I think, for patient care and also for the student learning, because they got to see that, as our experience of medicine is in these discrete care opportunities, but that is not the experience of the patient.
Thank you.
It must have been a challenge to incorporate students into the direct clinical team activities and help them understand the complex discharge process, which even in non-pandemic times is fraught with difficulties. How was this accomplished, and will you continue to refine the teaching elective goals as time goes on?
Yeah, I think in a lot of ways it was an exciting time. It was all hands on deck, although, we were really trying to limit the amount of providers seeing these patients to really create a model of care that we could then expand upon. But I think in the fun way is, like, students were ready to go. They wanted to be part of this. They didn't want to sit on the sidelines. And so we really had to figure out how we could, protect the student safety in a time of uncertainty. And it became quickly apparent that we could do this all remotely. And so the way we really organized this was just a series of huddles, kind of building on what was already existing in the hospital, a set of multidisciplinary rounds, but also really being intentional, setting up times where the students would sit down in front of video software or conference call and just run the list with the patients in a huddle. When I was on the ICU service, we would talk to palliative care every day. Then I would have a separate meeting with the students to kind of talk about what is happening in the medical way, and have the student and kind of create a plan for the students to reach out to families and coordinate with the social worker, nutritionist, the multidisciplinary team. And we kind of just scheduled that throughout the day. It was really important too, because as the providers are running around the hospital, it was hard. We're so used to families being in the room, and we just kind of pop in, we give them a update, and then we come back and make sure they understood all that's going on before they leave. But really having the students there to be more formally and intentionally talking to the patient was really helpful. And I think as this elective goes on, really a lot of the feedback we got from the students and maybe student Dr. Abedin can talk about that. How much happens after they're out of the hospital? How much do they retain, and what are their needs after that? And I think that, as Dr. Salib described, is a really dangerous period that we have to think through it and plan for, and really recognized in the COVID-19 population. And so I think that's going to be an important area to focus on as we move forward, especially for a lot of our patients who didn't have a medical home. And it's been exciting for us in the hospital. We really, students can be trailblazers. They just figure things out. They developed a workflow. They would, a couple of the projects of the students was to enumerate that workflow on run sheets that could be replicated. And we've kind of taken parts of that model and hired community health workers at our hospital to help with those care transitions for our certain vulnerable populations. And I think this is just important work for the medical team that should just be part of everyday care. And so we've really tried to build on what the students have done in this elective.
All right, Ms. Ahmedin, did I pronounce that correctly?
Yes, you did.
Okay, great. Thank you. Welcome. You are. It is refreshing to see you here and to know that you were a big part of this elective. And we certainly hope you can share a bit of your thoughts. You are actually representing the medical students who participated in this transitions of care elective. Will you share with us your perspectives about the elective, including the lessons learned and perhaps any learning gaps that were uncovered in the current undergraduate medical education curriculum in this particular topic or other topics?
Definitely, and I'm very happy to be here and answer this question and share my experience. I thought participating in this elective was extremely valuable, especially as was mentioned before, when we were not involved in clinical experiences due to the pandemic. It felt like it was an opportunity to really flesh out some of the theoretical aspects of health system science that we talk about in the classroom, to the tangible, really actually participating in those conversations and making those appointments with PCPs, talking with the families ourselves, and really getting that experience to know what it's actually like to then address or recognize the barriers that can be encountered when doing this work. In terms of filling the gaps of the current undergraduate medical education curriculum regarding transitions of care, I think we're really lucky at Dell Med, where these concepts are already emphasized from an early stage in our medical education. I did think participating in the elective provided an opportunity to kind of expound on this and have more experience just doing this work and doing it for 5 or 6 patients a day versus our 1 or 2 patients that we follow while on the wards, only kind of served as a way to further develop these skills and really exercise those muscles and become more proficient in participating in transitions of care, especially like whenever we're directly participating in it, we further understand the complexity of communicating with the family member, the complexity of really making sure that they understand what's going on, making sure that the patients understand what's going on, and additionally, understanding how difficult it can be sometimes to merge those worlds of the clinical continuum regarding inpatient versus outpatient medicine. And when you're the one making that call to the PCP, trying to do the warm handoff, you really do gain an appreciation for how difficult that can be sometimes. But I thought it was really great to have that experience, especially at a time where we wanted to participate in COVID care, but we're limited with access to PPE and safety at the time. And so I thought utilizing this opportunity was really innovative for our faculty here, and I felt pretty honored to participate in it.
Thank you.
We applaud your decision to obtain dual MD and MPH degrees at the UT Austin Dell School of Medicine. How do you believe the lessons learned during the transitions of care elective, how do you think they can be implemented in your clinical rotations and as you become a resident physician and practicing physician?
So I think there's so much evidence supporting the significance of optimizing a patient's experience outside the hospital, since we know how much that influences the outcomes in the hospital. And so this is something that's highlighted not only within the public health world at Dell and population health, but also something that's really emphasized to all Dell medical students. And so I think doing this elective just kind of served to reiterate that important point. And I felt like it was such a rewarding thing to be a part of as a medical student, and really contributes to that value-added medical education that we were talking about earlier in this conversation. And it's something that, as a resident, I will encourage my medical students to participate in, because one of the most significant things as a medical student on the wards is really feeling like you have ownership over your patient and that you are doing something that's contributing to the care of the patient. And this is a way, once you're introduced to the practical nature of this work and realizing that it doesn't actually add that much time to your day and does add a lot of value to the patient's outcomes, is something that can show that you are committed as a medical student to taking care of your patient. And then as a resident, to really delegate that work to a student to also participate in the healthcare of the patient. And so I think as I further on in my medical career, I will continue to highlight that this is something that anyone on the team can do. It's super important to exercise those muscles regarding family communication, regarding PCP communication. And I think it would only serve as a tangible way to reiterate kind of what we already know about what can help a patient while they're hospitalized.
Ms. Amidon, you will be a member of the second class to graduate from the Dell Medical School. Do you have a sense that the school has a platform that can implement new concepts in medical education faster than some other more established medical schools?
So I think that what makes Dell special is everyone's commitment to really challenging the status quo of what we do in healthcare spaces. And so everyone is willing to implement different systems, I think, more readily than other places. Only speaking from my experience, but if someone has an idea, we have our third year open to pursue a dual degree or do a research project that could be addressing that idea. And so I think the way that our curriculum is structured kind of lends itself to the innovative nature of kind of addressing topics like this. And so I think with our mission so tied to really improving patient care, patient outcomes, and their experiences with healthcare, and rethinking current models, having dedicated space within our curriculum to pursue those interests, I think definitely lends itself to maybe more readily addressing or changing certain ways that we do things, especially if we find that one way works better than another during that third year. And then we also may have that opportunity to pass that on, or whatever we learn, to another student who's going to be following in our footsteps potentially. And so I think having that time within our 4 years of medical school really does support that change-minded behavior.
Thank you. We wish you the very best in your medical career.
Thank you.
On behalf of the Southern Medical Association and Dr. Holt, thank you all for being here today. This has been a wonderful, wonderful conversation. And as we conclude, kind of wrap up, are there any additional points or comments you would each like to make now that we've had this discussion?
I would like to thank you for this opportunity. It's really been delightful to be able to share our experience. I wanted to share with you a couple of quotes, one from our medical student participants and the other from one of the teams who the students worked with. And so the first quote from one of our students says, "This elective has shed some light on the extent of the complexities of our medical system and highlights the need to strive for adequate communication between these complex parts for the benefit of the patient." And then I wanted to share a second quote, which is actually from one of the faculty members from one of the teams that the students rotated on virtually during the elective. So they note that the students played a pivotal role in communication with the family members of acutely sick patients interprofessional collaborations, as well as discharge planning and follow-up. So I think these statements summarize it all, just how pivotal the students' role was. And in addition to the education, how much they really contributed to our patients' care and to the teamwork. And thank you again.
Very nice confirmations of the strength of the elective. Thank you.
Does anyone else have any thoughts they would like to share, or pearls or final thoughts? Okay. Well, again, thank you so much for your time today. It's been a wonderful discussion, and we know your time is limited, so thank you for spending some with us.
We hope you enjoyed the practice of medicine. For more episodes in this series or SMA's The Business of Medicine podcast, go to sma.org/podcast or subscribe to us on iTunes, Google Play, Spotify, or wherever you get your podcasts. For more information about SMA's mission, please visit sma.org, and thank you for joining us today.